Hi, everyone. Welcome to the Lacked Fact podcast, which highlights recent clinically relevant research, policy statements, and protocols that you, as a practicing lactation professional, would probably like to know about. I'm your host, Dr. Eglash. I'm a board-certified family physician and breastfeeding and lactation medicine specialist at the University of Wisconsin School of Medicine and Public Health. This podcast is written and produced by the nonprofit organization IABLE, which is the Institute for the Advancement of Breastfeeding and Lactation Education. We have no commercial funders for this podcast series. Today's Lacked Fact comes from the following article, The Impact of Human Milk on Tympanostomy Tube, Hearing, and Speech Sequelae in Children with Cleft Palate. The first two authors are Hannah Piston and Noel Jabbour, published in the Cleft Palate Craniofacial Journal in 2025. As background, the authors state that children with cleft palate, with or without cleft lip, have a unique set of challenges that put them at risk for speech and language disorders. For example, they are very prone to otitis media with effusion, which can be accompanied by hearing loss, which then negatively impacts their speech and language development. This is because the middle ear does not aerate very well among children with cleft palate. Typically, these children have myringotomy tubes, which are tubes placed in the eardrums to alleviate and prevent fluid buildup in the middle ears. Those of us in clinical practice have experience seeing toddlers with a history of chronic middle ear fluid who really take off their speech skills after they have tubes placed. There's strong evidence that breastfeeding or receiving human milk decreases the risk of ear infections. The duration of breastfeeding does matter. For example, infants who breastfeed for 4 to 6 months have twice the risk of recurrent ear infections as compared to those who exclusively breastfeed for at least 6 months. The decreased risk of otitis media during breastfeeding is probably mediated by secretory IgA, which is the main antibody in breast milk, and by human milk oligosaccharides, which prevent adhesion of at least 2 key bacteria that cause ear infections, Haemophilus influenza and Strep pneumoniae. Children with cleft palate are at high risk for acute ear infections, but also chronic fluid in the middle ears, which is known as otitis media with effusion. The authors cite one study that identified a lower risk of otitis media with effusion among infants receiving human milk and a lower risk of having myringotomy tubes placed before 24 months of age compared to those who received no human milk. In this study, we're going to be talking about human milk feeding rather than breastfeeding among the study infants because most babies with cleft palate can't generate enough vacuum to remove milk from the breast directly and need to have milk expressed and fed to them in a specialty bottle. The authors in this study hypothesized that human milk feeding would result in a few different things. Number one, decreased prevalence of abnormal hearing exams before and after myringotomy tube placement. Number two, decreased number of tubes placed over time. And number three, better speech and language outcomes at 2 and 5 years of age. So this was a retrospective cohort study, which means that they reviewed the medical records of 319 children who were born between April 2005 and April 2015, who were cared for at the Cleft Craniofacial Clinic at Pittsburgh School of Medicine and who met their criteria. They had several exclusions, such as infants who had their cleft repaired at an outside hospital or who had other reasons for hearing loss, such as oral atresia. They also excluded babies who had no record of feeding history. Demographically, 95.5% of these infants were white, 13.5% had a genetic disorder, and 21% had Broban sequence. 49% had an isolated cleft palate, 34% had unilateral cleft lip and palate, and 16% had a bilateral cleft lip and palate. So among these 319 patients, 45% received some human milk, and among these infants, 45% received human milk for at least 3 months, and 23% received human milk for at least 6 months. The infants who received any human milk were more likely to have private insurance as compared to those who did not receive human milk. So just about all infants received myringotomy tubes. Most were placed before palate surgery, and the minority were placed during or after palate surgery. Fluid in the middle ears was measured by doing tympanograms, and abnormal tympanograms were found in at least one ear in 99% of children who received no human milk, and 85% of infants who received any human milk, 81% among those who received human milk for 3 months, and only 69% of children who received human milk for 6 months. The children who did not receive human milk were more likely to have 2 or more sets of myringotomy tubes by age 5 compared to those who received human milk for at least 3 months. So the age of last tube placement was younger among those who were fed human milk versus those who were not. In terms of hearing screens, 30% of newborns with cleft palate did not pass the newborn hearing screen, and these infants underwent repeated hearing screens before undergoing palate surgery. The infants who received human milk for at least 3 months were less likely to have abnormal follow-up hearing tests before having tubes placed. 77.8% of children who received human milk for at least 6 months had bilateral middle ear effusions at the first tube placement, compared to 93.3% of children who received no human milk. In terms of speech and language development, at 2 years of age, 52% of those who received any human milk had a speech language delay, compared to 64% of those who received no human milk. At 5 years of age, speech and language delay was present among 5% of those who received any amount of human milk, compared to 16% of those who did not receive human milk. So the bottom line is that infants with cleft palate greatly benefit from human milk feeding because they have less fluid in their middle ears. They're at less risk for acute otitis media, which means not having to be on antibiotics as much, and therefore experiencing less inflammation in their middle ears. They also are less likely to have recurrent tubes placed, which can cause chronic scarring and other complications of the eardrums. And this all translates into less chronic hearing loss and improved speech and language development over time. And if you think about it, the duration of time that these infants received human milk was rather short. It was only 23% of the 45% who received human milk that received human milk for 6 months. So it was a small percentage of babies who received human milk, yet there were some major differences in outcomes. Hopefully, craniofacial healthcare teams discuss infant feeding with their families and share that their babies will have better hearing, speech, and language outcomes if they provide human milk. These mothers and other lactating parents need a lot of support because they need to pump and bottle feed until at least paddle surgery is complete and possibly beyond. Hey everyone, thanks for listening. I encourage you to check out iAble at lacted.org, which is LACTED.org, to learn more about our educational projects, courses, educational handouts, videos, live conferences, and webinars. By becoming a member, you are not only supporting our free projects, but you will also receive a series of benefits, which you can learn about at our website. I'll be back with another LACT fact in a few weeks.